What's up, everybody? My name's Tanner Stewart, nurse with PHI Air Medical. I also work in the critical care unit. Today, we're going to be doing a very quick and basic lecture about understanding cardiac drips and the basics of ventilators. The goal for today is to take the understanding that you already have as far as treating shock patients and take it a step further, going past just the we need to treat this low blood pressure and move forward into something more of what is this low blood pressure a symptom of and how do I treat that cause? So we're going to get started, and I am going to go ahead and pre-apologize. This is my first time doing a video lecture like this, so I'm still learning as far as video editing and all that goes. And also I have my little baby girl here beside me, so if you hear any weird cuts or edits, that's because she was trying to give her 2 cents about how she feels about me not playing with her and recording this video. So let's jump straight into our patient care. We're a nurse working in the ER. We have a patient come in. She's an 88-year-old female. Patient was brought to us by her family for new onset confusion, low blood pressure. Family states that she was just discharged from this hospital 5 days ago after she had a coronary artery bypass graft. She said that the cardiologist was able to bypass 3 vessels and her care had been going good until today. So you get her into the ER, you move her over to your bed, hook her up to the vital signs, and this is what you see. We've got a heart rate of 110, a blood pressure of 76/48, respiratory rate of 26, an O2 saturation of 88%, and a temperature of 102.3. What do we think is happening, and how are we going to immediately respond to this situation? Now, this is something I had to learn moving from the critical care environment going into a pre-hospital and flight environment, is that we have to be investigators, okay? We have to be able to look at a little bit of evidence and try to make a conclusion on what's going wrong. I think sometimes we get spoiled in the ICUs that we have every type of number we can think of, and sometimes we don't have those numbers, but we still need to be able to figure out what's going on with these patients using our clinical judgment. So, right off the rip, I think we can all agree that the vital sign that jumps out first is going to be this low blood pressure. 76/48, MAP of 58, far too low. Critical care in me tells me MAP of less than 65, I'm going straight to Levofed, right? Like that seems to be our knee-jerk reaction of starting Levofed. And for 90% of our patient population, that would probably be a fine strategy. But we need to be digging deeper. What is that Levofed actually going to do to our patient? And is that going to fix the problem that is causing the hypotension? Well, that's where we need to be able to dig a little bit deeper and have a better understanding to move forward in our patient care. So let's just kind of go through some differential diagnoses here. So our heart rate is elevated at 110. Our blood pressure is low, SpO2 low, and look, our temperature is elevated. So immediately, I know all the ER nurses are saying she's septic. Right off the rip, she's got the high temp, she's got the elevated heart rate, low blood pressure. This is sepsis all day long. She needs fluids and she needs pressors. And to that, I would 100% agree with you. But let's also look at some of the other things. She just got back from having a cabbage procedure 3 days ago. What if her grafts closed? And this is actually cardiogenic shock. The grafts that are feeding blood into those heart chambers aren't able to do that, and so her heart is not functioning at that 100% capacity. What if the graft's ruptured and she's bleeding out, and this is a hypovolemic shock, and that's why her heart rate is high? Or, what if she threw a PE? Maybe she wasn't taking her blood thinners that she got. She hadn't had a chance to go to the pharmacy yet, and now she's thrown a PE, and that's why our O2 sats are low. You can see where there's a million possibilities for things that could be going on, and how each one of those possibilities may require a different strategy in our treatment. So today we're going to talk about how to determine what's going on based off of what we can see, how we can recommend things to our doctors and to our PAs and nurse practitioners, and also when we're given, especially in the ICU, options of PRN medicines of I've got 3 drips running, how do I know which one to titrate up and which one to titrate down? That's what we want to focus on. Getting away from just the Levoped's going to fix blood pressure and getting more into the Levoped is going to affect my heart and my vessels in this way. So, if you've been up in the ICU for any amount of time, or you're taking care of these post-CABG patients, you may have seen that they have these cardiac output monitors, numbers that you don't often see on patients unless they have a Swan-Ganz catheter in. Things like systemic vascular resistance, cardiac output, cardiac index, all of these numbers. And I think after a while, we get embarrassed if we don't know what the normals are or what they mean. We just think to ourselves, I'm one of the nurses that's been here the longest. I should probably already know this, and I'm too embarrassed at this point to ask, or I really don't care to ask. I'm just going to start them on Levophed and get that blood pressure up, and then I can, go on with my day. So today we're going to go through these numbers and talk about what these are actually telling us and how they can drive what we're going to do or what we should be doing for our patients. So before we get into the next level stuff, let's actually take a step back and just go over the basics of our heart to make sure we all are at a equal starting field. So we have our heart, and remember this is the patient's heart. So anatomical position, the right heart is actually going to be on the left side. Left heart's going to be on the right side with these representations. So don't get confused if somebody's saying right-sided heart failure and you're thinking it's this one over here. Well, no, it's the patient's right side. So when we talk about the blood flow going through the body, everything starts here in the right atrium. This is like the bouncer at a club. Blood is brought to this atrium by the inferior vena cava, or the IVC, that's going to be important later on, and the superior vena cava. Both of those dump blood into this right atrium. It fills up. It delivers the blood into the right ventricle. That then shoots it forward into the lungs. That blood comes back oxygenated into the left atrium, sent down to the left ventricle, and then it is delivered into the rest of the body from there. The cycle continues. So we want to go over and understand that shock happens when there is a problem or a disruption in that flow. And we're going to talk today about how we measure the different areas of the heart to figure out where the problem lies. Okay? So we'll get rid of this. We'll go forward. Starting at the very beginning, our CVPs, central venous pressure. Remember I told you everything starts in the right atrium. All the fluid is brought to there, and the right atrium decides who gets to come into the heart and who does not. So this catheter is put up through the vein, and it drops right there at the right atrium, and it measures the pressure outside the right atrium to give us a basic idea of fluid volume status. Though it can't give us the exact fluid volume, it can tell us based off the pressure that is inside that atrium how much fluid. Are we low? Is it low pressure or is it high pressure? And then from there, if it is a low CVP, we know, hey, this patient's dry. They have no preload. Preload means you ain't got no bullets in the chamber, so you can't fire the gun. If your CVP is high, it says, hey, something's happened. There is a backup of blood flow. You think about a long highway, and if we've got this long highway, and there's a wreck right here, well, you're going to have this backup and this high pressure of traffic behind where the wreck is. Everything past the wreck over here will be open and free. It'll be low pressure because nothing can get through and get past it. So if we start seeing a high CVP over here, we think that we're in fluid volume overload. And we got to start asking ourselves, why? Why are we in that overload? Why do we have this high pressure? Okay, so that measures preload of the body. Now let's talk about the middle of our heart. A Swan-Ganz catheter, typically in the Baptist ICU, you'll see these with patients who are coming out of a CABG procedure. It's typically the only time that you'll see them. So the important things to remember here is this catheter is going to be fed in through the arterial system. It's going to go in through the right atrium. It's going to go down through the right ventricle, and it is going to sit right in the middle of this pulmonary artery. And it's going to measure a PA pressure, so just your pulmonary artery pressure. Similar to the CVP, it's trying to measure the pressure before you go into the lungs to see, hey, how is our volume status? Is there blood backing up inside the lungs that's causing high pressure? So it all relates back to how I think of it as, where is the car wreck? Where is the backup of traffic? Because if you can find the traffic, then you can find the wreck. We use that in the air. If they call us out to a scene call for an MVC, but we don't have an exact location, then we'll find the highway and we'll just trace the traffic down, and eventually we'll be like, oh, well, there's the wreck that's blocking the flow. This is the same thing we can do with these numbers. So we have this pulmonary artery catheter that's measuring our PA pressures, and this is looking for pulmonary hypertension. And so the exact ranges, normal range, is about 12 to 16. Considered in pulmonary hypertension when you're above 25. The way I remember those numbers is I just think a dime to a quarter is what I need it to be. So, if you get above 16, it's a little bit too much, but I know a dime is fine, so 10, and a quarter is too much. So between 10 and 25, especially for your post-op CABG patients, you expect it to be a little bit high, but that's my rule of thumb for remembering it. But 12 to 16 is your normal range. Pulmonary wedge pressure is what you do when you inflate this little bulb down here on the bottom. So if you'll notice, there's this little 1.5 cc syringe that comes attached, and it is actually filled with helium inside of this syringe. And when it is inflated, it completely occludes this pulmonary artery. It rides that balloon up and it sits right there and it wedges in between the two of it, so no blood flow can move forward. And the tip of that catheter will actually measure what is called your wedge pressure. And that's looking at your actual pulmonary left-sided pressures. So it's a good way to be able to tell how your left ventricle is functioning is by getting these wedge pressures. Now, in the CCU, I believe under Baptist policy, we are not allowed as nurses to wedge PA pressures. That's something that either an MP or the cardiologist would do, but just be aware that is something that they may do, and it is something that can happen. So also always check this syringe when it comes back from surgery. There's a lock on it right down here. You want to make sure that there's no air inside of it and that this lock is pushed. And the way that it'll look is there'll be like a little 2 red lines, and then there'll be this horizontal line right here. If the horizontal line is all lined up, it's unlocked and it is able to push air through it. But if the lines are off centered like this, then that means that syringe is locked and you cannot put air into it. So just always make sure that you have this offset of red lines on the syringe so that you don't accidentally wedge your patient while you're moving them up in the bed or if they turn or something like that. Because that would be less than good. You can only wedge your patients for about 6 seconds before you start having issues. All right, this isn't something we're typically going to see, but I just wanted to go over pulmonary hypertension and that wedge pressures are an option. Never know when we might get a cardiologist that wants those to be done, and it might come into our wheelhouse later on. All right, now let's talk about the meat and potatoes. This is the stuff that we're going to be dealing with on a day in, day out basis even if we cannot see these numbers, we should still have them in the back of our minds of, hey, what is going on with these patients? So stroke volume is the amount of blood we pump every single heartbeat. So they can measure that through ultrasound. They'll put some contrast into the heart and they'll see how much with one squeeze, how much of that blood is ejected outside of the heart. That's where we get our ejection fraction from. So we want it to be at least 60 to 100. When you start getting less than that, you start thinking about your different types of heart failure. Maybe they have hypertrophy, maybe the heart's weak and it just can't squeeze. But when your stroke volume drops, your blood volume leaving the heart is going down. So that gets into our next part of cardiac output. That is, you're taking your stroke volume and you're looking at your stroke volume over a whole minute. How much blood in 1 minute can this heart pump out? So the normal range for that is 4 to 8 liters a minute. And the thing I want to really emphasize here is that cardiac output and blood pressure are two very different things. You can have a good blood pressure and a terrible cardiac output. Vice versa, you can have a great cardiac output and a terrible blood pressure. The way I think about cardiac output, and I believe there's a slide coming up on this, but if you think of it as a water hose, it's the amount of water coming out of the hose and you're trying to fill up a bucket or a swimming pool or something like that. You can put your thumb over top of that water hose to increase the pressure, but the amount of water coming out of the hose is still the same. The only way that you can increase the cardiac output is to go over to the spigot on the side of your house and crank it up and get more blood flow going through that heart. And that's where either preload or stroke volume comes into play. And we'll go into that a little bit deeper here in just a little bit. Cardiac index is similar to your cardiac output, but think of it as like the map of your cardiac output. It's going to take it and it's going to average it out based off of patient size. So with this one, we're going to have this machine, and when you go to initially put the patient onto it, typically surgery does this, they'll program in the patient's age and their weight, and their height, and it'll calculate all the things together and it'll average out their cardiac output and give you a cardiac index number. Normal cardiac index range is 2.5 to 4. That's what we wanted. I know with the cabbage patients, when Dr. Eubanks was here, he wanted it at least above 2. If it got less than 2, you're dumping in albumin and you're starting to think about starting medicines. But 2.5 to 4, that's the cardiac index that we are looking for. Now let's go over the last piece of this slide. Systemic vascular resistance. This is the squeeze of the vessels. So if we go back and we think about our water hose analogy, and you have your cardiac output and your blood pressure, the systemic vascular resistance, let's say this is like a dissection of your arterial. This is where all the blood flow is coming out. And let's just say that our systemic vascular resistance it's on the low side, it's 800. This is a wide vessel. That means that all the blood is going to be sitting low in this vessel. There's not a lot of pressure into it. So when we increase the systemic vascular resistance, we shrink the size of that vessel to where there's not as much room and it increases the pressure of that blood flow. And again, going back to, you think of a water hose and you're trying to wash your car or you're playing on slip and slides as a kid. If you're not being able to shoot the water as far as you want to be able to, if you put your thumb over the tip of that water hose and start to occlude part of it, it tightens the exit and it makes it to where that water is high pressure and it pushes it forward faster. Again, it does not change the amount of water that is leaving, but it increases the pressure of how much water is coming out. So now we have an understanding of what each individual number means as far as on the cardiovascular side. So let's take all these pieces and put them together to get a true picture of what our patient looks like. So remember, we talked about hypotension is a symptom and not a cause. Causes of hypotension are going to come from this right here, your different types of shock. So we're not going to go through every single one. I just made a very simple and straightforward guide to show you how each one reacts differently. So we'll go through just like one or two just so you can understand what the chart means. So hypovolemic shock. That is, we have a decreased amount of fluid inside our vascular system causing a low blood pressure. What is that going to show us? Well, how does our body typically respond to low volume hypotension? It's going to try to correct and compensate for that by increasing your SVR, which we said that's going to tighten down the arteries. But you're going to see a decrease in your cardiac output and your cardiac index. Why? Because it's going to directly affect your stroke volume. We talked about this when we talked about CVP. If your preload is down and your heart is empty, you've got no bullets in your gun. There's nothing left to fire. So with this patient specifically, if they came into the ER in hypovolemic shock and our knee-jerk reaction is just, hey, their blood pressure is low, let's start them on Levophed, are we really doing what they need? Because our body already is going to increase the SVR. Our body already is going to increase the heart rate. So what is that Levophed really doing for us? Not much, right? What is the core of this problem? It is the decreased cardiac output because they have no preload. They need volume. So this hypotension cannot be solved with Levophed, but rather they need volume. They need to be replenished inside of their venous system. So if it's a trauma, give them blood. If it's dehydration or a burn or something that's caused their fluid volume to leave outside of the vessels and go into third spacing or whatever, then they would need LR, normal saline. And I know what you're probably asking yourself is, well, Tanner, I work in the ER. We don't drop Swan scan catheters. We don't have the availability to be able to see a cardiac output or what a SVR is. So knowing these numbers is great and all, but how can I actually use this in practice? Fantastic question. Let me tell you. We use our assessment skills to figure out what is the body showing us as signs of decreased cardiac output. One of the fastest way, especially for the hypovolemic shocks, that we can tell, hey, do I need to give my patient fluids or do I need to give my patient a compressor, is talk with a doctor and ultrasound that inferior vena cava. We talked about that at the beginning of the lecture. We said, hey, this is very important. With a fast exam, you can scan the inferior vena cava, and if it is collapsing with each breath, it just looks wimpy. Well, what is that telling us? It's saying, hey, that vena cava that stores all that fluid about to go into the heart, it's very low pressure. Every time we breathe, that diaphragm's closing it. It doesn't have a lot of pressure behind it, which means it can't have a lot of fluid there. So, hey, let's give this patient some fluids, okay? And let's see what our blood pressure is after that. If we scan them and that IVC is just plump, it's not collapsible, then we know, hey, they've got plenty of fluid in their heart. We can see this IVC. There's a line to get in that club that goes around the corner. So, fluid is not the problem. Now we need to go into giving them something to help increase the stroke volume. We need something that's going to move that blood forward or to tighten those vessels. As far as cardiac output, well, how can we tell what the cardiac output is for them? Like we're not going to get echoes on everybody to look at the stroke volume. Well, look at the capillary refill. That's one of the most overlooked assessments that nurses make, and it's one of the most important. If they're not having a good cardiac output, if they're not getting blood to those organs, then your urine output is going to decrease. So we can look at these different pieces of our patient profile during our assessment and use that as a guide to bring to our doctors, being like, hey, doc, Miss Ethel over there in trauma one, she's hypotensive, she's tachycardic. I think she might be, low on fluids. Would you be okay doing a fast scan of the IVC to see if we need fluids or if we need pressors? Or you do your assessment and say, hey, doc, she's got 3+ pitting edema, very decreased capillary refill, and she hasn't made urine in 8 hours. I think we need to do something about this. When you go to present to a doctor as a problem, come with some solutions, come with some evidence to back up your claims with your assessment. But this is just an example of not all hypotension is created equal. Now look at this one right here. Early sepsis. So let's think back to our granny, our 88-year-old that came into the ER that we were talking about. She was hypotensive and had a fresh cabbage, right? So septic patients, we see these all the time. We have those purple sheets, they have these septic alerts because it's going to increase your heart rate and it's going to decrease your SVR, decrease your blood pressure. But in early sepsis, your cardiac output and your cardiac index, it may be fine. But why is that? Our blood pressure is going down. Why would our cardiac output stay the same or maybe even go up slightly? Because as our SVR decreases and that artery starts to widen, more blood flow is allowed to leave out of there. And the pressure your heart has to push against, it goes down. So your heart, for a little bit, will actually be able to have a stronger cardiac output because there's more space for blood to move and your heart rate's going up. So for a minute, you might be doing okay. Your body will be able to compensate. But as you get into later and later stages of sepsis, now our SVR drops even more, and our body can no longer keep up with this compensation because it's kind of like attaching a fire hose to the side of your house. You can turn on the knob full blast, but you're going to have water just trickling out the end. It's going to take forever to get there because there's no pressure behind it. It's just too big of a hose. So this is the really quick list just to show the different types of shock that all will result in a decrease in blood pressure, but they all need to be treated from a different perspective. All right, so we have an understanding of what our numbers mean, what our different shock types look like. So let's go ahead and let's try to put it into some practice. Let's look at some real world. Let's go back to old Ethel over here. She's been admitted to the critical care unit. The doc placed a Swan-Ganz catheter at the bedside, and then here are the numbers that we've been given, okay? So we've got cardiac output of 7, an index of 4, SVR of 550, CVP of 8, pulmonary pressures of 15. So immediately, the only one that jumps out to us as a problem should be the SVR. Remember, 800 to 1200 is our normal. 550 is too low. Too low is too wide. That's how we remember it. Too low is too wide. So cardiac output is fine. SVR is decreased. And if we look back to her vital signs from before, remember she's very tachycardic. What does that fall into on our last chart that we saw? Early sepsis. Okay. So when they came into the ER, I'm sure the ER nurses noticed it. They started her on some fluids. It's 30 milliliters per kilogram is the sepsis protocol. That's why these purple sheets are so important, because we need to make sure that our patients are getting adequately fluid volume resuscitated so we can eliminate that from potential problem lists. So the ER probably gave her some fluids. That's why our CVP is a little bit better. And then our SVR is decreased. So we're in early sepsis. We know she's hypotensive. We're pretty darn sure she's early sepsis. We're going to have to obviously wait for blood cultures and other lab values and all that. But with this information that we have, we need to start thinking, what medicines does she need to fix this blood pressure? Because remember, before she was mapping like 48, 58, something like that. So we don't have time to wait for lab to run all her blood work. We need to make a decision right now. We need to work with the doctors and come up with a plan right now for her in this acute phase. So we're going to start going through, and instead of talking about each medicine individually and Levofed is this and blah blah blah, start making nursing drug cards like we did in nursing school. Let's focus on drug classes and what each medicine is actually doing to the patient. Okay, so alpha and beta receptors. These are your adrenergic receptors. When your body goes into the fight or flight mode, it produces natural hormones such as epinephrine and norepinephrine. You're being shot at, you've been in a car wreck, whatever's happening, your body goes into that overdrive fight or flight mode. And it starts dumping epinephrine and norepinephrine into your bloodstream, sending signals to your body saying, "Hey, it's time to go. Like, we're in danger. We want to survive." We know what epi and levo does, so this is the same thing. So we're giving this patient external forms of these hormones. They work on the alpha receptors and the beta receptors. So we'll go into some detail about what those are. Vasopressin is a different story. It works on your V1, V2. We're not going to go too deep into that one today, but just know that as a primary, alpha and beta receptors are the two big ones that we worry about. So with our alpha receptors, when we think alpha, we think large. We think, what's the biggest thing that's going to contribute to this patient? Blood vessels. So they're primarily found in the smooth muscle, and when they are activated, they cause constriction. The SVR increases. So beta receptors, they're broken down into two different beta receptors. There's beta 1 and beta 2. The easiest way that I have to remember these is I have one heart, but I have two lungs. So beta 1s, they're working on my heart. They're going to increase my chronotropy, so increase your heart rate, and they're also going to increase the contractility. Basically, they're going to make my heart squeeze harder. So with beta 1, it's fully heart focused, and it's going to cause it to beat faster and beat stronger. So think back to your cardiac output. What's that going to do to it, the beta 1? It's going to send it to the moon, right? Because we're going to be squeezing harder, so that stroke volume is going up, and we're beating faster. So that's going to make that cardiac output, that stroke volume multiplied by your heart rate, it's going to go up through the roof. Beta 2s, their primary effect is on the lungs. So you're going to have bronchodilation. That's the reason why we give racemic epi and why we give epinephrine to asthmatics, is because it causes that bronchodilation. But it can also cause vasodilation. So if you have a medicine that is a beta 1 and beta 2, then think about what's going to happen to your cardiac output. You're going to decrease your SVR, so you're going to widen those arteries, but you're also going to increase your stroke volume and increase your heart rate. So what is that going to do to your cardiac output? It's going to send it soaring. With this medicine, we think about dobutamine. Okay, this is those cardiogenic shock patients. Their heart's just weak and wimpy. We put them on dobutamine, and it makes it where they don't have to pump as hard to move blood, but it's gonna make them pump like a madman, and it's gonna make them pump fast. But with knowing this, even though dobutamine can increase your cardiac output, it can decrease your blood pressure, because it's still a vasodilator. So with this, you need to be careful. If you've got to order for a patient and they're 90s over 60s, and you're given an order to give dobutamine, be careful. You might want to preload them with some Levophed or some fluids because we know with that vasodilation, with that SVR decrease, there stands a chance of that blood pressure dropping. May not be a ton, but it is something to look out for and be aware of. So those are our two primary receptors. Alpha is going to work on the arterial system. It's going to work on all of our blood vessels. And then beta 1, one heart, is going to make us pump hard, make us pump fast. And then 2, it's all about dilation, dilation of the lungs and dilation of the blood vessels. So now that we have that under wraps, we understand the alpha and beta receptors, let's take a look at our medicines. Okay, this is just an overview breakdown, very simplified form of what each one of these pressors does to these cardiac numbers. So Levophed, this is our first line in a lot of things. You see we're having huge SVR increases. This is going to constrict very high because it's got that alpha properties, okay? But you see it also has beta 1 properties, meaning that it's going to send our heart rate up and it's also going to increase that rate and that squeeze to give us that increased cardiac output. So Levophed, kind of our first line drug here in the ICU, especially in septic patients. This is going to be your go-to gold standard drug is going to be Levophed. Other medicines, epinephrine, this hits all three of the receptors. So we're getting alpha, beta 1, and beta 2. And as you can see, we have a major SVR increase, cardiac output increase, and heart rate increase because we're hitting all three of those receptors. One thing to be very mindful with when it comes to epinephrine is patients that are already tachycardic, especially like trauma patients and stuff like that. If they're already in the 110s, 120s, epinephrine may not be the best drug to give because increasing that heart rate even more leans more to the likelihood of sending them into lethal rhythms. So if you've got a patient and they're tacking along in the 110s, 120s, we might want to start looking at some other alternatives to our medicines, okay? Vasopressin, this is the one that we said it hits different receptors. So this is going to hit our V1 and V2 receptors, which is going to be very important here in just a minute when we talk about our ABGs and how our ABGs and how our pH of our blood really affects how well these medicines can work. All of these medicines are going to trigger in receptors on proteins in the cell. And as the pH changes, those proteins denature. So if the receptor is a lock and the medicine is a key, as the pH changes with acidosis, it makes it to where that key does not fit into the lock as well. So patients that are extremely acidotic, their alpha and beta receptors may not work as well, but with vasopressin being a V1 and V2 that's primarily triggering on the kidneys, this does work well in patients that are extremely acidotic. This is also our second line, kind of like a catalytic drug that we give with Levophed whenever we hit about the midway point. So what used to be 15 or 20 mics, now I guess is 2.5 with the new weight-based standards. We give this medicine, and what it does is the V1 is going to cause vasoconstriction, so it increases our SVR, but V2 is sending a chemical down to the kidneys saying, hey, don't pee any of this fluid out. We need all of it. So it is keeping that fluid inside of your body to be reused, keeping those pipes full and that pressure up. So as you can see here, it doesn't really have an effect on the cardiac output. It can, with you increasing that fluid, or really not increasing the fluid, but decreasing the excretion of fluid. It's going to have more fluid in the pipes be used. And it's also not going to affect your heart rate at all. So tachycardic patients, this is a good second line drug to use with them. Phenylephrine, this is a fantastic medicine that's becoming more and more popular, especially in pre-hospital transport. This is nothing but alpha. So you are getting extreme SVR. You are clamping those veins down crazy tight and you are having no heart rate changes and next to no cardiac output changes. Now you see here it's got a decrease beside the cardiac output numbers. Why is that? Because you got to think about it. Your SVR is your vascular resistance. So the tighter your arterial system is, the harder your heart has to push against it. That's where that pressure comes from. You get to a point where if you make that resistance so high, your heart can't push against it, so that will decrease your stroke volume and decrease your cardiac output. So it's like a seesaw. We have to find that right level of keeping the blood pressure up high enough without killing our cardiac output. So this is a fantastic medicine, especially with a neurogenic shock patient, because they're having this just vast dumpage of their SVR. Their body has no signals being sent to increase their heart rate. And then finally, we talked about dobutamine already. That is a beta 1 and beta 2 medication that is going to increase your cardiac output, but does have the potential to lower that blood pressure because of the vasodilation. So again, the thing to just keep in mind with all of these medications are we have to find a balance. We have to make sure that we are keeping adequate blood pressures, but also that we are keeping an adequate cardiac output. So we need to make sure we're watching for urine output, color, mentation, all of those things as we are titrating these medicines. So that's a brief overview of some of the main ones. Like I said, you can go way deeper into these. I'm not going to sit here and bore you going just through medicine after medicine. We're going to keep trucking along. So going back to our patient here, she's admitted to the CCU. So we're down to a respiratory rate of 8 and an SpO2 of 78. So what's concerning us here? The blood pressure for sure, but now also we've decompensated so much that we're starting to go into respiratory failure. Okay, what drugs should she be started on? This lady is really looking septic to us. Levophed is the gold standard drug. So let's just real quick talk about the new weight-based dosing profile. The benefit of this is that with this new weight-based formula, we're able to give higher dosages. So they're actually able to receive more medication, but there also comes with additional risks with this new weight-based formula. First off being it's a much tighter parameter. So instead of going up by 5 micrograms, we're going up by 0.05 micrograms. So easy mistake that can be made is putting in 0.5 micrograms per kilogram per minute instead of 0.05. So take your time and always verify your dosage with your rate. If your rate is 80 to 90 milliliters an hour, double check yourself because it should never be going that fast. Remember, with Levophed, we're having alpha and beta 1 properties, so we're going to have an increase in contractility and chronotropy. That's our heart rate. And anytime that we put medicines that are going to affect the heart like that, we increase our risk of going into lethal rhythms, throwing PVCs. So just be extra careful as we're dosing these patients. All right, so let's go back to our patient here in the ER. She's breathing terrible. We've got her started on Levophed now. Doc says we need to draw some ABGs. Here are her blood gases. Okay, so let's just quickly go through these really fast to see if we can determine what she's got going on. pH of 7.1, CO2 of 50, bicarb of 12, a PaO2 of 55, and a lactic of 8.5. So when you go through this and you do your whole blood gas calculation, take a second, figure it out, and what do you think she has going? All right, so we know that her pH falls onto the acidic side of things. We're below 7.35. So we know that's an acidic. Her CO2 is 50, so she's in the acidic range for CO2. But look at this, her bicarb is low. It's only 12, which is also acidic. Normally with your gases, you'd have one that was acidic and one that leans more basic. But this one, they're both acidic. So that makes this a mixed acidosis. Not only is she in a respiratory acidosis due to her respiratory rate only being 8 breaths a minute, but she's also having some kidney damage, probably due to the low cardiac output. So now we're getting hit from both ends. She's not breathing off the CO2 that she needs to be, and also her body cannot produce bicarb the way that it needs to. Right here, we look at our PaO2. This is a very specific look at how well the blood is oxygenated. She's at 55. Most places have a gold standard rule of less than 60. You're on your way to an intubation. And then right here, look at this lactate level of 8.5. That's showing us that we are in anaerobic metabolism. So we do not have the oxygen needed to do the full Krebs cycle to produce our oxygen. And we're having all this nasty byproduct being caused by anaerobic metabolism. So this lady is sick as stink and needs to eat some plastic very quickly. So let's talk about what that looks like and go through intubation. All right. Before we get deep into intubation, let's talk about, once again, a basic overview. When we breathe, our lungs work off of a negative pressure system. So what that means is we breathe passively. The diaphragm drops down, and that dropping of the diaphragm causes a vacuum which pulls air into our lungs. As the diaphragm releases, it pushes the air passively back out of our lungs. What does that mean? It means that our lungs are used to very low pressures. When we intubate someone, we take that negative pressure system that our bodies are used to and we completely reverse it. Now we are no longer negative pressure breathing, but we are now positive pressure breathing. We are forcing air into their lungs with pressure. And this is a big responsibility that we take on for these patients. We are fully taking away their ability to breathe for themselves, and with that comes a higher chance of mortality and a lower chance of getting to leave the hospital. So let's look at peri-intubation adverse events. A hospital in Brazil, 18 hospitals actually in Brazil, looked at acute intubations inside of the ER. These are not coding patients. These were not patients that were coming in for outpatient surgeries. These were patients that came into ERs with acute hypoxia and required intubation, and they looked at this over 2 years. And the results they found were pretty jarring. So what they found was the patients that came in and that were intubated with no hypoxic episodes and no hypotension had a 15% mortality, or basically a 15% chance of dying while they were in the hospital. Patients that had a hypoxic and hypotensive episode within 5 minutes of intubation had a 60% chance of dying within the next 28 days while at the hospital. So we go from 15% chance to basically a coin flip by not being able to control their O2 saturation and their blood pressure during intubations. So what does that mean for us as healthcare providers that are going to be assisting with these intubations? What it means is we need to be pre-oxygenating and preparing these patients before we give the induction medicines. So a patient that is breathing room air, they have not been pre-oxygenated, a normal healthy adult can last 45 to 60 seconds of apnea after receiving sedation and paralytics. That means that the doctor or the paramedic has 45 to 60 seconds to open the mouth, get the blade in, find the vocal cords, pass the ET tube, pass the vocal cords, remove the stylet, attach the bag, and start bagging that patient before their O2 sat drops below 90%. That's not a lot of time to do it, and that's in healthy adults. Imagine the adults that are already sick coming in requiring intubation. That time is a lot less. All right? What can we do to help increase this time? So one thing we can do is passive oxygenation, putting a high flow nasal cannula underneath a BVM mask. What that does is twofold. It increases the amount of oxygen this patient's being exposed to, and also leaving the nasal cannula in their nose during the intubation process gives them passive oxygenation and has actually been proven to increase apnea times, giving that doctor more time to get that tube passed without hypotension. We can do proper BVM technique, meaning that as long as we can get this airway open and we can bag this patient, the emergency is over. Remember, the tube is just the final product. What we're really looking for is to move air in and move air out. So, good, proper BVM technique means that we can slow down the whole run and say, hey guys, we've got time. Okay, we're going to bag this patient, get their O2 sats, adequately prepare our patient, and have everything ready before we make this O2 spot. Slow down the road. Take time to pre-oxygenate your patient and denitrogenate your patient. So remember, the atmosphere is 20%. So that means if the atmosphere is 20%, then our lungs are also 21%. The rest of it is they're smaller gases. So what we mean by denitrogenate your lungs, draw really bad, is that if this is all the oxygen down here and the rest of it is nitrogen, we need to be pumping these full of oxygen, pushing all that nitrogen outside of it. That way, whenever we're not inflating and deflating this, we still have a whole bucket full of oxygen for the body to pull from. That's what denitrogenation is. And then finally, we need to be having someone designated to watch the monitor during these intubation attempts. These standard SpO2 probes have about a 15 to 30-second delay on them. So the number that you're actually seeing on the monitor was their O2 saturation 15 to 30 seconds ago. So if we see sats of 93, we need to be mentioning that to those doing the intubation. That way we can go ahead and pull out, rebag, and try again. Because as we saw, hypoxia alone has a 40% mortality rate. So it's our responsibility to make sure that we are giving this patient the best chance of survival possible. This slide right here was absolutely mind-boggling to me when I first learned about it. So this is the oxyhemoglobin desaturation curve. What does that mean to us? Patients that are adequately pre-oxygenated, they did a study on this to see what is apnea time that they can have. So these are patients who have received sedatives and induction medicine. How much time can we have without them breathing apnea pre-oxygenated? So if you look here, this is obese patients. We pre-oxygenate them all the way up to 100%. Let's say that we're going to pull out of our ET tube around 3, so that's like here. That patient would nearly 2.5 minutes. So here's 100% here for these patients. 93 is probably right there. That means that we would have roughly 2.5 minutes of apnea time for that doctor or OT to look for the cords and to pass that to on a moderately ill patient. So this is somebody that we can't get their sats even above 95, but we still deoxygenate them. That is still giving us a 5-minute apnea time before they sat below. That is insane that just taking a few extra minutes before pushing the induction meds, we can give a normal adult 8 minutes apnea time before their sats drop. If you can't find vocal cords in 8 minutes, then we're in way deep. All right, so we've covered the basics of the lungs. We've covered the intubation process. Now they're on the vent. What do we do? Let's go over just some of the most basic vent settings so we can all be on the same page of what the goal is for the patient. So starting off, we have our tidal volume. This is the amount of air being delivered with each breath. Typically, this is set in volume. So you'll see your patient who's on a 450 tidal volume. They are getting 450 milliliters of air, however that's calculated out through the ventilator. But 450 is what we're being put into the patient. Next, we have the PEEP. This is the amount of pressure after we get done with the full breath. So we breathe them in, and then when we breathe out, this is the amount of pressure left inside the lungs. PEEP is so important because what it does is it lets those lungs just sit there open and it keeps those alveolar sacs from collapsing in on each other. This is what they talk about when they say recruitment. This is what they mean is they want these lungs to expand and pop open to increase the surface area so more air touches more parts of the lungs for gas exchange. Next, we have FiO2. That's just a fancy way of saying how much oxygen is being delivered. And then finally, the easiest one is just the respiratory rate. That's just how many times are we wanting them to breathe a minute. Okay? Now, why do we use ideal body weight for ventilators and we use actual body weight for medicines? Well, because if you look at this picture right here, even in morbidly obese patients, the lungs are the exact same size. So if you were to do 6 to 8 milliliters per kilogram of actual body weight, you would explode these lungs. So that's why we have to do ideal body weight whenever we are doing the ventilator. So if you ever see a new RT or a paramedic or a flight nurse coming in and they are basing their tidal volume off of actual body weight, you need to stop and question that because we can kill a patient very quickly if we use the wrong number. All right. Next, let's talk about common alarms that we're going to see in the ICU and how can we treat them. Okay. So the first alarm we're going to see, we see this one a ton, is the high pressure alarm. Every ventilator calls it something different. Some of them call it high pressure, some call it high peak pressure. But basically, there is something constricting the airflow in and out of the ventilator. So this is measuring the pressure inside the actual ET tube and the tube of the ventilator itself. So if this pressure increases, you need to be looking for kinks in your line, something got sat on top of the line, maybe the patient's waking up and they're starting to bite the tube. But high pressure alarms mean that the ventilator's having to push harder against something inside the lungs. This can also be a huge indicator that your patient has developed a pneumo. So if you are putting a patient on a ventilator and they're breathing fine and then all of a sudden they get a high pressure alarm, you need to do what's called the DOPE mnemonic. DIOPE. You look for displacement. So has the tube been moved? Are we no longer inside the vocal cords? You look for the O of obstructions. Maybe they've got lots of secretions or they need suction. Maybe there's something kinking off the tube. We don't know. We look for, so that's displacement, obstruction, a pneumothorax. So we need to listen to the lung sounds and see, hey, do we have equal sounds on both sides? Or did we give this patient a pneumo? And finally, E is equipment. Is there equipment failing somewhere in the system? That's the dope mnemonic for high pressure alarms. So when we talk about pneumos, let's talk about this for a second. We said normally we breathe on a negative pressure system. So our pressures are very low. Our bodies can sometimes hide pneumothoraxes. Those can happen spontaneously with especially older people with weak lungs. They sneeze and try to cover their mouth, and that pressure can cause a little tear inside of the lung. Well, the pleural cavity is a completely closed vacuum system. So air does not need to escape out of the lungs and into the pleural cavity because if it does, it takes up valuable real estate and it makes it where the lungs cannot fully expand to their full potential. If the lungs cannot expand to their full potential, they cannot oxygenate to their full potential. And as that pneumothorax continues to expand over time and expand, eventually it will take up so much real estate that it will push the lungs and the heart over to the opposite side that will kink off the vena cava, causing a tension pneumo. These are the big bad ones we learned about in school. They talk about the tracheal deviation and all that. Tracheal deviation is a late sign. If you wait to find that, your patient will be dead before you notice it. We need to find these quick and early. You'll have an absence of air moving on one side, and you will have a decrease in blood pressure and an increased work of breathing. Persistent high pressure alarms after you've gone through your dope mnemonic, really be thinking about pneumothoraxes. All right. Low pressure alarms, they're the exact opposite. You start looking for leaks and disconnects. So maybe we had extra long tubing and we rolled the patient and it got cracked. And so now we have air leaking outside of the circuit. Sometimes we get a drink from a restaurant, they give us a straw, and there's a small crack inside the straw. We try to drink it, and we can't get that full gulp of drink because we're losing our suction and our pressure because of that crack in the straw. The same thing will happen with these ventilators. If there is a leak or a disconnection, they will not get the air that they need in their lungs. So this can be a very big problem. We need to address it very quickly. Always start at your patient and then work your way to your machine. So look first at the actual ET tube. Is it connected or has the ET tube and the circuit become disconnected from each other? That's the most common cause of this alarm. If so, all you have to do is just connect those two right back together. The ventilator should automatically pick up and start breathing for them again. If you don't see a disconnect there, you can start working your way down the tube, listening and feeling for air movement. If you find a crack inside of the ET tubing, remove that patient from the ventilator, call RT, and bag that patient. With low pressure alarms or a cracked tube, you will not be getting what you need. You have to bag this person. All right? Low minute volume, that just means they're not getting the amount of air that they're supposed to be getting. Minute volume is like the lung version of cardiac output. This is, we want to see how much air we can move in a minute. So a low minute volume, the RT will set an expected minute volume inside that vent, and especially if the patient's on a spontaneous rate. If they're not meeting that, it'll alarm at you, hey, this patient is not breathing at the rate and the amount that we need them to, so we need to be checking on them. So maybe that person, they're on a spontaneous breathing trial and they're just not good and we need to put them back on a regular rate, or maybe there's a leak. So, anyways, if you hear that low minute volume, go in there, assess your patient, look for leaks, and then call RT and say, hey, they're hitting low minute volumes. We might need to go ahead and put them back on their rate. An apnea alarm, that is the ventilator detects no breaths whatsoever. So this is especially seen again in spontaneous breathing modes when the patient is driving their own respiratory. If they're not breathing and not pulling their own breath, this alarm will go off and say, hey, they're apneic. They're not breathing. So then the ventilator will kick in and breathe for them. Typically, there's backup rates set in the vents, but if this is a persistent alarm, call your RT and let them know so they can come and put a rate in there for you. High rate, again, the exact opposite of the last one. It's just that patient's over breathing so much This is an under-sedated patient. So one of two things need to happen. We need to turn that propofol back up, give them some pain medicine, or we need to be getting this patient ready to extubate. If they're breathing that hard and that fast, do they need that breathing tube? That's a conversation to be had with the doctors and the RTs. But especially in sick patients you're on a transport, if you start getting a high rate alarm, be looking to make sure your propofol hasn't run dry and your patient's probably hurting. So go ahead and get them some fentanyl or something like that. Low PEEP is exactly that. The PEEP is so low, it just can't hold the baseline pressure. With that, you like we said, you worry about losing all of the recruitment that you've gathered, and it can end up decreasing your O2 sat. High PEEP is way more of a problem. So this typically will come in with patients who are breathing at an extremely high rate, and they'll start breathing again before the last breath is finished, and it causes what's called auto PEEP. So to give you a quick example, if this is the waveform on the ventilator, okay? So we breathe in, we breathe out, right there. PEEP would be the amount of pressure right here. I can't draw on this keyboard. But PEEP would be what's left inside the lungs whenever we're done breathing. Try this again. So breathe in and breathe out. This baseline line right here is your PEEP. So if our PEEP is set at 5, whenever our breath is done, our baseline should return back to that pressure of 5. But what happens is if we breathe in and then before we fully breathe out, we breathe in again, we stack on top that PEEP. So now we have that 5 from the last breath plus 5 from this breath because we didn't get rid of it. So now we have 10 of PEEP. And if we let that high rate continue, we will stack and stack and stack and stack, and to the point where our PEEP will be so high that we cannot breathe in and out. So definitely want to watch for that. The quickest fix for auto PEEP is to disconnect your patient from the ventilator and compress their chest down to expel all of that excess air inside of their lungs. All right, end-tidal CO2, what is it even good for? So, end-tidal CO2 is measuring the amount of expiratory CO2 in your lungs. So remember, going all the way back to like biology, chemistry, as your body goes through the Krebs cycle to produce ATP, which is our body's form of energy, it has carbon dioxide as the byproduct of that cellular respiration. So CO2 is showing us, hey, our body is producing energy as it's supposed to. So end-tidal CO2 in itself is a perfusion indicator because it's telling us that we're having blood get to those organs and those organs are able to use it and convert it into energy. But what it's also telling us is it can confirm our airway for us because if you're trying to differentiate, is my ET tube in the esophagus or is my ET tube in the trachea, there should be no CO2 inside of the belly. Now, you can have some if you've been bagging the patient before you intubate them. Sometimes you can force air and CO2 into the stomach. That's why those colorimetric end-tidal detectors aren't the best. And also with those colorimetric detectors, the ones that turn from purple to gold, those are just pH paper that as soon as they get exposed to that CO2, they change colors and they never change back to their original color. So it'll tell you, hey, yeah, I detected CO2, but it won't give you a consistent reading saying, hey, I can guarantee you that you are inside of the lungs right now. Another thing that end-tidal will tell us is real-time ventilation data. So with patients that are in respiratory acidosis, we expect them to compensate that by increasing their respiratory rate. So we can see that compensation with a decrease in end-tidal CO2. Think back to our lady that we talked about, our septic lady at the beginning of this lecture. She originally was breathing very quickly. She was breathing like 22 times a minute, I think that it was. because she was acidotic. So we didn't know it, but her body did. She was compensating for that acidosis by trying to blow off that CO2. So knowing this can help us drive our ventilator care. If we know, hey, she's acidotic, she has a pH of 7.1, let's try to maintain her respiratory rate where we get an end tidal of 20 to 25. All right. So end tidal is a great tool. It's fantastic, especially for post-intubated patients. So you've with taking the ET tube out of the patient's back breathing on his own, but we're still concerned of how they're going to do respiratory wise. They make nasal cannula end tidal detectors, and if that end tidal starts to climb, it tells us, hey, they cannot breathe adequately enough to expel that CO2. We probably need to come in either with some BiPAP or with another breathing tube to prevent them from gaining so much CO2 that it makes them acidic again. So end tidal CO2, we're about to start using it for conscious sedation, but hopefully in the near future we'll start using it for more of our intubated patients and more of our lethargic level of conscious patients because it can tell you how well a person is keeping up with their metabolic demand and if a person needs to be intubated minutes before a SpO2 detector will. All right, so let's start to wrap things up. We've talked about different shock states. We've talked about how that can determine our treatment plan and that not all blood pressures are created equal. Different shocks require different game plans and different medications. So we also talked about how we're going to work with our docs and RTs. At the end of the day, we're all up here for the same reason, and that's to treat our patients and get them out of here as quickly and as safely as possible. All right. So that's all I got for today's lecture. I know it was a long one, but you're going to see your drips and your ventilators pretty often back here in the CCU. If you have any questions about the lecture or if there's any other topics you'd like to see covered, just holler at me. I work PRN there over at PHI. I'm pretty easy to find. So thank y'all for your time. Thanks for watching.